Picture this. A family walks up to your pharmacy counter, they're all excited for their first camping trip of the season, and they ask you a question you are going to hear a lot in the coming months. What's the best insect repellent for us and the kids? Now, that simple question is the doorway to a really critical public health conversation, and that's where you, the pharmacist, are just so central. So let's break down exactly what you need to know.
And this conversation has truly never been more urgent. I mean, just to put this into perspective, the number of reported Lyme disease cases in Canada, it surged from just 144 back in 2009 to over 3,000 by 2021. And let's be honest, that number is probably way lower than the real count. This isn't some niche issue anymore. It's a rapidly growing challenge that's literally happening in our own backyards.
So that really brings us to the big question, doesn't it? With these numbers climbing, what is our role? Well, it's so much more than just slapping a label on a bottle, right? We are on the front lines. We're perfectly positioned to guide our patients through every single stage, from that first question about bug spray to managing their treatment and everything that comes after.
So here's how we're going to tackle this. We're going to walk through the entire patient journey. We'll kick things off with prevention, then cover the big what now after a bite. We'll talk about recognizing the signs, dive deep into the medications and the key counseling points, discuss what happens after treatment, and then really wrap it all up by cementing your vital role in the community. Okay, first things first, prevention. You know, this is where we can make the biggest difference. The absolute best way to handle Lyme disease is to just avoid getting that tick bite in the first place. Our counseling here is truly the first and most important line of defense for every single one of our patients.
So when that family asks you for a repellent, we've got some really specific evidence-based advice we can give. For adults, DET up to 30% is a great option. But for kids, it gets a bit more nuanced. Now, what's really interesting is that for kids between 6 months and 12 years, Health Canada actually points us towards icarinine as the preferred choice. It lasts longer, too. We're talking 8 to 10 hours at a 20% concentration, which is a fantastic counseling point for parents. And for both, it's absolutely crucial to remind them, not for infants under 6 months old.
You know you're going to get this question. I found a tick on my kid, how do I get it out? Your instructions need to be super direct and clear. Tell them, use clean, fine-tip tweezers. Get as close to the skin as you possibly can and grasp the head. Then, and this is the key part, pull straight up, nice and steady. Don't twist it, don't jerk it. Afterwards, clean the area really well. And here's a pro tip for your counseling. Tell them to save the tick in a sealed bag or container. It can be a huge help for public health later on.
All right, so the inevitable happens. The bite. You get that panicked call at the pharmacy. I just pulled a tick off my daughter. Does she need an antibiotic right now? This is our next critical moment, and knowing the guidelines for post-exposure prophylaxis, or PEP, is absolutely key to giving them the right advice. The guidelines give us this really handy 3-point checklist to run through for PEP. First question, is it even a problem where they are? Is the patient in a high-risk area where more than 20% of the local ticks are infected with the bacteria? Now, you're not expected to know this off the top of your head, right? The key takeaway here is to know where to find it. Your local public health unit's website is going to be your best friend for this kind of data. Second, we need to think about the tick itself and how long it was there. It has to be a black-legged tick, which, by the way, is exactly why telling patients to save the tick is such a great idea. And even more important, was it attached for at least 36 hours? You see, that 36-hour mark is really the magic number. That's when the risk of transmission just shoots way up. A good clue you can give patients is that a tick that's been feeding that long will look really full, engorged. And finally, number 3. It all comes down to the clock. Prophylaxis is really only an option if it can be started within 72 hours of when the tick was removed. If you're outside of that window, the chance for prevention is gone, and the strategy has to shift to just watching and waiting for any symptoms to appear. So if you check all 3 of those boxes, yes, yes, and yes, then the guidelines recommend a single dose of doxycycline. For adults, it's 200 milligrams. For kids under 45 kilos, it's 4 milligrams per kilogram. And it's good to have some perspective on this. The number needed to treat to prevent just 1 case of Lyme disease is around 50. So it's not a silver bullet by any means. But in these very specific high-risk situations, it's a really valuable tool to have.
But what about when PEP isn't an option? Or the bite was missed entirely? Here's a really crucial fact to keep in your back pocket. Up to half of all patients who get Lyme disease have no memory of ever being bitten by a tick. None. That makes our ability to recognize the clinical signs so incredibly important, because we might just be the first healthcare professional that patient talks to about what's going on.
If you don't catch it, Lyme disease is, well,
It's a bit of a slow-motion train wreck. It moves through these distinct stages. It starts in that early, localized phase. That's when you see the classic rash and those vague flu-like symptoms. Weeks or months later, it can spread, causing much more serious problems like facial nerve palsy or even heart issues. And if it's still missed, it can move into late disease, causing things like debilitating arthritis and serious neurological problems.
Okay, let's zoom in on that classic sign, the erythema migrans, or EM rash, because this is where a lot of confusion happens. So how do we tell this apart from a regular bug bite? It's all about the combination of clues. The EM rash gets big, at least 5 centimeters across, and it's usually not sore or itchy. It also shows up about a week or more after the bite, not right away. And while everyone thinks of the bullseye, we have to tell our patients it can just as easily be a solid red patch.
All right, now we're getting into our bread and butter, right? The prescription for Lyme disease comes in. Our role now shifts to making sure that treatment is safe, it's effective, and we're providing that essential counseling that helps patients stick with it and know what to expect. So this table gives you a really nice at-a-glance look at the first-line options. And you'll see a theme here. Doxycycline is the big one. It's a real workhorse, especially for things like facial palsy. But for that initial EM rash or for later-stage arthritis, amoxicillin and cefuroxime are great oral alternatives. Also, pay attention to the durations. They can range from 10 days for a simple rash all the way up to 28 days for arthritis.
Okay, let's drill down on doxycycline, because this is the one you'll be dispensing most. There are 4 things you absolutely have to tell your patients. 1, photosensitivity is a real thing. Sunscreen, hats, long sleeves, the whole deal. 2, GI upset. Tell them to take it with food, but, and this is so important, separate it from dairy, antacids, and iron by at least 2 to 3 hours. 3, you can reassure parents. The data shows it's safe for courses of 21 days or less in kids of any age. And 4, don't forget, if they can't swallow pills, a liquid suspension can be compounded.
So what about amoxicillin and cefuroxime? When do they come into play? Well, their biggest advantage is a huge one. They don't cause photosensitivity. That can be a major selling point for patients during the summer months. They're also our go-to agents for treating mild or localized Lyme disease during pregnancy, which makes them absolutely essential tools in our toolbox.
Okay, this next one is super important to mention because it can really freak patients out if they're not expecting it. It's called the Jarisch-Herxheimer reaction. Within the first day of starting treatment, about 15% of patients might suddenly get a fever, chills, and muscle aches. You have to tell them this is not an allergic reaction. It's actually a sign the antibiotic is working. It's killing the bacteria, which then release these toxins. Reassure them it goes away on its own and can be managed with something like an NSAID.
All right, let's talk about something that can be really, really tough. It's the patient who finishes their antibiotics, but they come back to you and say they still don't feel right. They're still dealing with fatigue, pain, or that frustrating brain fog. This is a situation that calls for a lot of empathy, but also a really firm grasp of the evidence.
And this is where we have to lean on the evidence. And the guidelines are really clear on this point. This quote says it all. There's no solid proof that these lingering symptoms mean there's an ongoing infection. And even more importantly, major studies have shown that giving more and more antibiotics doesn't help these symptoms and, in fact, can cause real harm. Our job here is to support the patient, absolutely, but also to gently reinforce what the evidence tells us about long-term antibiotic therapy.
So when you step back and look at the whole picture, it's pretty amazing, right? From that first conversation in the bug spray aisle all the way to the dispensary counter, your role is just so multifaceted. You're an educator on prevention, you're a trusted guide in those tense moments after a tick bite, you're a clinician making sure therapy is right, and a counselor for these complex patient concerns. You are a truly vital public health resource in your community.
So as we wrap this up, I want to leave you with one final thought. We've gone over the data, the guidelines, the critical counseling points. Now, as tick season really gets going, the real question is, how will you proactively use this knowledge to educate your patients, to support your colleagues, and ultimately to protect your community? Because that's the real measure of our impact.